Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is on the lower GI tract, which includes ulcerative colitis, perforation, Crohn's disease, diverticulitis, and there's also a couple little added things in there like the appendix and small bowel obstructions. What I want you to keep in mind is that a lot of these disease processes of the lower GI tract encompass the same assessments, a lot of the same interventions, and same diagnostic testing. So don't rack your brain over trying to figure out what the difference is between all of them, because they're other than the actual disease process itself, a lot of the assessment interventions and diagnostics are the same. So just kind of keep those in mind, and it makes it a little bit easier. So the first one is ulcerative colitis. It's an inflammatory disease of the bowel that results in poor absorption of nutrients. It starts in the rectum and spreads upward toward the cecum. It usually affects the large intestines. It's usually a continuous pattern, and it usually affects the innermost lining of the intestines. The colon becomes edematous, and with that, it could lead to lesions that start to bleed. And if the body can't take care of that as far as healing them, then ulcers will occur. And if those ulcers get bad enough, then it actually may lead to perforation. If those lesions and ulcers can actually resolve themselves, it will lead to scar tissue. That scar tissue will lead to loss of elasticity, which is the loss of ability to absorb nutrients. With colitis, there's a lot of remissions and exacerbations. So, your patient may go through a period of colitis and the symptoms that they have, and then they may get better, and then 6 months later they may get it again. It may be a year, it may be a couple years. It really is just a matter of whether or not whatever is going on in life, whether it's infection, whether it's stress. There's a lot of factors that will lead to exacerbations, and again, that's really based on how often those happen will lead to the exacerbations of colitis itself. So with the acute and chronic, again, acute is short-term, chronic is obviously long-term. With acute exacerbations, they're going to have vascular congestion. They're going to possibly have some hemorrhaging. Again, that's probably from the lesions and the ulcers themselves. With the colitis, they're going to have some edema in the innermost lining and ulceration in the bowel mucosa. So again, this is really just more of, the swelling comes, and with the swelling, it possibly can lead to lesions, and then lead from lesions to ulcers, and then from ulcers to actual bleeding. With chronic, this is after all this has happened and they get better, and then they get it again and get better and get it again, that chronic colitis will lead to muscular hypertrophy, which will lead to fat deposits and fibrous tissue. This will essentially lead to bowel thickening, shortening, and narrowing, which will then possibly lead them to small bowel obstructions or other problems. As far as assessment-wise, they're going to have anorexia, and all these assessment symptoms that you actually see from your patient is really due to the fact that whatever goes in must come out. And with the lower GI problems, whatever goes in tends to come out as fast as it went in. And that doesn't allow your patient to actually absorb the nutrients that they would have gotten if it would have stuck around and actually been processed, digested, and absorbed. So the anorexia is either they're having nausea and vomiting and don't feel like eating, or they're not. Anorexia is actually from whatever they are consuming is just not sticking with them. With that, they're going to have weight loss. They're not going to feel good. With colitis, other symptoms are going to be abdominal tenderness and cramping, and that's because of the diarrhea. They're possibly going to have some blood and mucus in their stools, and that's because of the fact that, again, the lesions led to ulcers. Those ulcers are starting to bleed, and that's where you're going to get the either the blood-streaked bowel movements, or based on where it is, can lead to also be tarry, because of the fact that it's a little bit higher up, and it's clotting, and it's eventually moving out. They're also going to have malnutrition because they're not eating well or not absorbing. They're definitely going to have dehydration because of the amount of diarrhea that they're actually having, and this also leads to electrolyte imbalances. So don't forget to look at potassiums and sodium and magnesium and phosphorus, all those electrolytes, to find out what are they losing every time they're having their bowel movements. Because of malnutrition, they're going to have anemia, and they're also going to have a vitamin K deficiency. Intervention-wise, for the acute phase, they're definitely going to be NPO. You want to give the bowels a rest. You're definitely going to give them some fluids, whether it's normal saline, whether it's D5. Whatever IV fluid you give them is to help get them back to being hydrated. You're going to look at their electrolytes. So if their potassium's off, their magnesium is off, you're going to replace those. TPN is something that we actually give them, and we'll go over that in another slide, but it's another IV bag that we give, and that's because of the fact that there's too many electrolytes that are off, and instead of us constantly hanging bags over and over and over again, the TPN actually is a big, huge bag that has all that they actually need, and because they're NPO, they're not able or don't want to consume anything, so the TPN is going to go through a PICC line or a central line, and it allows them to get all the electrolytes that they actually need. It's easier for us, it's easier for the patient, it's a little bit more exact, and like I said, we'll go over that in a couple slides. You want to limit their activity to reduce intestinal strain. You're definitely going to monitor their bowel sounds, which are probably going to be hyperactive, and that's because the fact that the intestines are working so hard to get whatever it is in them out, and even though there isn't anything in there, it's really just the bowels are trying to deal with that inflammation. You're definitely going to monitor their stools for color consistency and whether or not there's actually any blood. If there is blood, that means that they are bleeding in their intestinal tract somewhere. We have to watch their H&H to make sure that they're not bleeding too much. And you also want to look at consistency. Is it starting to become formed? Is it becoming too loose? You're looking at color. Is it dark and tarry? Is it is it brown? I mean, you're really looking at it because it just kind of tells you somewhat as far as what's going on with your patient. So here's your PPN and your TPN. Again, the picture that I put on here, the yellow bag, it's a really big, large bag. That bag has all the electrolytes that they actually need. The lab will draw the phlebotomy will draw labs first thing in the morning, and what will happen is you will find out what the electrolytes are. The pharmacy will actually make this bag based on those lab results, and then that evening you actually start them on TPN. The TPN will again give them the magnesium and the potassium and the sodium and the phosphorus and the chloride and all the things they actually need on a continuous basis, and it only can go through a PICC line or a central venous catheter. And again, this is to help save us time from actually having to hang them, but then again, it's also a little more exact. If their potassium's low, the pharmacy knows exactly how much to put in that bag so that way they can keep their potassium back up. And they're constantly losing this stuff because they're constantly having diarrhea. So again, they're going to draw labs every single day and kind of make this bag based on those lab values. The white bag that's next to it is actually lipids, and because your patient is NPO and they are getting lots of fluids and they're not getting anything else, they also need fat content. So the lipids are there to help with that. Intervention-wise, you're going to definitely make them NPO. The being NPO is to actually give their bowels a rest, but as they get better, they can actually move them to a clear liquid diet, and then if they can tolerate that well, then they'll actually put them in low fiber, and then low fiber and high protein, and vitamins and iron. What you want to do is you want to assess your patient every time they eat, because if they did clear liquids and they were fine, low fiber seems to be okay, but then when they went to the low fiber and high protein and they didn't tolerate that well, then you'll go back to the low fiber. So you want to do a diet as tolerated, but you need to find out what they can tolerate. So whatever they can't tolerate, put them back to the stage they were before. You're definitely going to avoid foods with milk. That tends to cause more mucus in the digestive tract. Avoid whole wheat, grains, nuts, raw fruits, and vegetables. Those are very hard to digest, so you're really just putting more pressure on the abdomen and more pain. You're going to limit their, well, obviously they shouldn't drink because that makes them more dehydrated, and they're already getting dehydrated from the amount of diarrhea that they're having. And then caffeine is a vasoconstrictor, so it not only does it cause constriction in the bowels, but you also have that that inner lining that's inflamed, so you're just causing more problems on that. And plus also caffeine can possibly dehydrate them even more. You're going to take or give your patient meds such as salicylate compounds, which will help bind things together. Corticosteroids is really good because they're anti-inflammatories. You can give them immunosuppressants because colitis and Crohn's and a lot of the abdominal disease process tend to be autoimmune. And you also do antidiarrheals, which will help slow that process down. So when they are feeling better and well enough to eat normal foods, their body's not still trying to break it down and push it out as fast as they possibly can. All right, so as far as other interventions or assessments, you're going to monitor for bowel perforation, peritonitis, and hemorrhage. This is important because, again, when we go back to the idea that they're going to have the exacerbation, it's going to cause some lesions and possibly some ulcers. It's now that we really need to watch them and make sure that nothing more serious is going on. So again, you're going to monitor for bowel perforations, peritonitis, and hemorrhaging. That's looking at their bowel movements, whether or not they're either blood streaked or if they're actually bleeding profusely every time they actually have a bowel movement. You're going to look at your patient as far as guarding of the abdomen, increased fever and chills, which is usually an indication that there's infection brewing or something going on. You're looking at pallor because obviously the more they're bleeding internally, the more pallor they'll have. Progressive abdominal distension and abdominal pain, which is a sign of internal bleeding. Restlessness and tachycardia and tachypnea. You're definitely going to look at all their bowel movements to make sure that, whatever you're able to at least look at it and go, okay, this looks like a exacerbation of colitis, or maybe something else is going on. And again, if those ulcers perforate, you now have intestinal content that's now spilling into the abdominal cavity. That's a lot of infection. That's a lot of bleeding, and you can't just see that. So you have to really pay attention to your patient and look at their vitals. If their blood pressure starts to go low and their heart rate tends to go high, then they are going through some sort of shock, and that's due to the fact that they're bleeding internally. So this is probably the most important as far as to see if the disease process has gone from just an exacerbation to something much more serious. Surgical interventions, we'll go over this in lab and also a little more in detail in class. But if the colitis gets too bad and the exacerbations are too frequent, they can actually cut out the diseased part of the bowels and either suture them together, or they actually can put in what they call an ileostomy or a colostomy bag, and this is allowing not only the intestines to have some sort of rest, but also you're taking out the diseased part of the bowels, which was causing the problems in the first place. Now on to Crohn's. So it's an inflammatory disease that can occur anywhere in the GI tract. It tends to affect the small intestines, but this also is going to affect the entire thickness of the bowel wall. It leads to thickening, scarring, narrowing of the lumen. It can lead to fistulas, ulcerations, and abscesses. This isn't too far off as far as colitis. So intervention-wise, assessment-wise, they tend to kind of be about the same. So don't rack your brain over trying to figure out what is what. They tend to be both about the same. It's just really more of anatomically, where are they? And again, you're really assessing your patient to find out what's going on, and that will determine what interventions need to take place. So as far as assessment-wise, you're going to have some fever, cramp-like colicky pain after meals. You'll have some diarrhea with some mucus and pus, abdominal distension, anorexia, nausea, and vomiting. Again, your patient is not feeling well. Either they don't feel like eating and they can't, or they don't, which will lead to anorexia, or that whatever they are consuming is making them nauseous, they're vomiting, and that will also lead to anorexia. It will also lead to weight loss based on the fact that either whatever is going in is coming out and can't be absorbed, or they're just not consuming at all. This will also lead to anemia, electrolyte imbalances, and definitely dehydration and malnutrition. Intervention-wise, again, you're going back to NPO. You want to give the bowel some rest, and giving the bowel some rest will also not necessarily eliminate the pain, but it'll at least alleviate some of it, so that way they're not causing the intestines to try to work so hard. Definitely give them some fluids, whether it's normal saline or T5. You want to make them hydrated. You're definitely going to watch their electrolytes. Again, if the electrolytes are too off, then you'll actually do TPN. You'll limit their activity to reduce intestinal strain. Monitor bowel sounds, monitor stools for color, consistency, and blood. Again, you're looking to find out if some of those lesions have turned into ulcers, and if those ulcers turned into a perforation. Other interventions, again, you're going back to the NPO. You're going to advance their diet as tolerated, so you could possibly put them in clear liquids. Then you're going to advance them to low fiber, high protein, and then add the vitamins and the iron. Again, if they're not tolerating one of those steps, then go back to where you were before, because you don't want to start them all the way back to an NPO. But if they tolerate the clear liquids fine, not only are you hydrating the patient, but you're also getting them something in their belly, and that actually may work, and that might be what they're on for a couple days. But again, if you start them off too fast and too far on the chain, then you might have to go back to the beginning. Again, avoid foods that contain milk, whole wheat, grains, nuts, raw fruits, vegetables, pepper, alcohol, and caffeine. And again, the corticosteroids doesn't help with the inflammation. The immunosuppressants, again, based on the fact that it's an autoimmune disease, and then antidiarrheals to help slow the process down. Diagnostic testing, and this kind of goes mostly for all lower GI problems. They'll do x-rays, CT scan. They may do a leukocyte scintigraphy, which is a white blood cell count, which indicates whether or not there's inflammation, which it's one of those things where we kind of know that they already have the inflammation, that we're really just kind of proving it. They will possibly do endoscopy or a colonoscopy. The endoscopy will actually do an EGD, which means they're going to put a scope up down in their mouth, down their throat, into their stomach, and then into the small bowels, or a colonoscopy where they'll actually go rectally and all the way up to the large bowels as far as they could possibly go. They're looking for that inflammation. They're looking for lesions and ulcers, and if there is any bleeding, and where is it, and they're looking for that disease process. They also could do an MRI and possibly an ultrasound. So as far as Crohn's and surgery, again, the Crohn's tends to be in the small intestines, or even these pictures here, it shows that it could be essentially anywhere, but it's that disease process that it's really affecting certain points of the intestines themselves, and what they can do is actually remove those areas. And again, they're try to sew them back together, or they may actually do some sort of either ileostomy or a colostomy bag just to eliminate those symptoms. And that is reversible. So if they're able to do this and 6 months later, actually put this back together, it's definitely going to be better for the patient. Not only physically and visually they'll feel better, but also, I mean, I think the process of doing a colostomy or an ileostomy, it just causes other issues, and we can talk about those in class too. But again, they'll do the surgery to remove those infected areas and try to make the patient feel better. Here's another picture of the inflammatory bowel disease. So we've got the first one is what a healthy bowel looks like, and then the Crohn's disease, obviously it's a thickening of the entire wall, and then with ulcerative colitis, it's actually within just the innermost lining. So the next disease process is diverticulosis and diverticulitis. Diverticulosis is an outpouching or herniation of the intestinal mucosa. It can occur anywhere in the GI tract, but most common in the sigmoid colon. With diverticulitis, the inflammation of one or more diverticula that occurs from penetration of fecal matter. So you have diverticuli that actually lines the intestinal tract itself, or the lining of the intestines. When that becomes inflamed, you have the diverticulosis, and then diverticulitis is actually that lining actually has these little pouches all along the entire tract itself, and when things get stuck in there, then it actually causes an inflammation of the diverticuli. This can result in abscesses, formation, or perforation. So if something gets stuck in them, then the body will try to get rid of it, and if it can't, it'll actually wall it off and cause an abscess. If it goes for too long, then it will actually turn into an ulcer, and then it'll actually perforate. Again, your intestines are an encapsulated organ, so when ulcers happen and then things start to perforate, now you've got intestinal content spilling into the abdominal cavity, and this will actually cause generalized peritonitis. Here's a picture of that. So again, it's the lining that actually starts to become inflamed, and then those pouches themselves get stuck, stuff stuck in them, and then that actually causes the diverticulitis itself, and then it will cause either an abscess or perforation and cause infection. Assessment-wise, usually affects the left lower quadrant, which will cause abdominal pain that increases with coughing, straining, and lifting. You'll definitely have an elevated temperature based on the infection itself. You'll have nausea and vomiting. You'll have flatulence. You'll have cramp-like pain because the body's trying to get rid of that. You'll have abdominal distension and tenderness, and you may have possible blood in their stools. If there is blood in the stools, then again, you've gone from lesion to ulcer, from ulcer to perforation, and now it's become a bigger issue. Diagnostic-wise, I did mention the EGD and the colonoscopy. For an EGD, basically the scope goes down their throat into their stomach and into their small intestines. They are looking for, again, inflammation. They're looking for perforations, they're looking for ulcers, they're looking for lesions, they're looking for all those things in the small intestines. Your patient is definitely going to be NPO. Make sure you have a consent form signed, making sure that they actually understand the process itself. Now, as far as colonoscopy, it's the same concept. They're basically going from rectum through the large intestines and looking for something. The picture that I show here is what they call either bowel prep or go lightly. Basically, they have to drink this jug of water that has medication in it that is going to clean out their intestinal tract. They usually start in the afternoon, and they will literally have a bowel movement almost every hour until whatever is going in is coming out, and it's nothing but clear. And that's because when they do the colonoscopy, they don't want to look at your stool. They want to look at nice, clean, empty bowels, so that way they actually can look for all these problems. Lab-wise, they're going to look at inflammatory markers such as the white blood cell count, and they're also going to look at something called a C-reactive protein, which is an inflammation. Intervention-wise, you're going to provide bed rest. Obviously, make them NPO. You can advance them to clear liquids if they can tolerate it. Fiber diet gradually. Again, you're monitoring for perforation, hemorrhaging, fistulas, and abscesses. You definitely, if they are in clear liquids, you want to advance their intake as far as fluids for 2,500 to 3,000 cc's a day, and that's to keep not only them hydrated, but based on these disease processes, whether it was Crohn's or colitis, diverticulitis, because of the amount of diarrhea that they're having, you want to have them at least replace that. Soft, high fiber foods will help with bulk, but obviously not during the inflammation, because obviously if you're creating more bulky bowel movements and there's an inflammation, they're going to get stuck. So, and this is probably more so on the fact that, once they feel better and they can actually advance it as a normal diet, then have them have the high fiber foods. Avoid gas-forming foods because that causes abdominal distension and pain. Avoid nuts and seeds because they tend to get trapped in the diverticula, and that's what actually causes the inflammation. Eat a small amount of bran daily, so that way you can actually, again, start to bulk the stools that they actually have. Surgical interventions, we mentioned this before. We've got the colon resection, so they can cut out the disease processes and either surgically put them back together, or if they can't, then they'll actually do the colostomy or the ileostomy. The picture on the right is actually a picture of the part of the intestines that are coming through the intestinal wall onto the outside of the body. The round disc is what they call a wafer, and on the picture on the left is actually the pouch itself, and they actually snap together like a Ziploc bag. So, and this is how the patient has a bowel movement, and they either can reverse it based on everything coming down. Usually you give them about 6 months, and sometimes they don't reverse it or can't reverse it at all. So, but we'll have a lab on colostomy bags and ileostomies, and we'll talk more about this in class. Medication-wise, so I want you to be familiar with them. There is a list in Canvas as far as the GI meds that I want you to know, but here's kind of some of them. So we got Cipro, which is a antibiotic. We've got Flagyl, which is also an antibiotic that are specifically for the bowels. Pain meds, all the GI disease processes based on pain, you're going to do IV because obviously they're NPO. So you can do morphine or Dilaudid. They're also going to do nausea meds because, the more nausea they have, the more they don't feel good. The more nausea they have, the more they vomit. That causes more pain on their abdomen. So you definitely want to control their nausea, which will help control the pain and make them feel better. So the next disease process is the bowel obstruction. So we've got a common type of obstruction or blockage is called a fecal impaction. Fecal impaction is when a large hard mass of stool gets stuck in your digestive tract and it can't be pushed out by the normal way. So when the bowel is blocked by something other than hard stool, doctors call it a bowel obstruction. So common causes could be either twisted bowels, herniated bowels, tumors that are blocking the intestinal tract, blood vessels that are engorged. We've also got muscle walls becoming paralyzed, such as patients who have abdominal surgeries or any surgery. Anesthetic will slow that down. So another thing I want to bring up, and probably gear it more towards this, is that bowel obstructions usually happen for whatever reason, but basically what goes in is not coming out. So when you do your assessments and your interventions, do it more towards the idea that we want things to come out and they're not. So, and I'll explain. So as far as assessment wise, you're going to physically assess them. You're going to look for a health history. Are they taking pain medications that could have caused the actual constipation, which led to the small bowel obstruction? Are they drinking enough water? If it's 115 degrees outside and they're, hiking Camelback Mountain and they're not drinking enough water, that will dehydrate them. And being dehydrated doesn't allow the intestines to have the ability to push things through. And are they physically active? Patients who are bedbound aren't physically active. And if they're not physically active, things slow down and things get stuck. Find out, how long they've been constipated, what led to them being constipated. Is there any flatulence? No flatulence means things aren't moving. How long has that been? Find out if there are stomach cramps. Are they coming and going? Is there nausea and vomiting, diarrhea? Is there abdominal distension? The nausea and vomiting, diarrhea is kind of important because, patients who, let's say, had the flu and are nauseous and vomiting, they don't realize that they're losing all the fluids by vomiting, or because of the nausea, they're not drinking enough water, or diarrhea can lead to dehydration. So it really comes down to you trying to figure out, how did it happen? How long have you had it? What are your symptoms? And trying to figure out if it either can be fixed or if there's something bigger. Diagnostic wise, they're going to do an x-ray or a CT scan. Here are pictures of an x-ray of patients who have had a small bowel obstruction. And basically, again, what went in didn't come out and it just sat there. Intervention wise, okay, so this is where I wanted you to kind of gear it towards the idea of having a small bowel obstruction and whatever is going in is not coming out. So the NG tube, and we'll have a lab on this, but basically it's a tube that you put up their nose, down their throat, and into their stomach. The reason why we do this is to be able to suck out gastric content that your body is naturally producing. Your body will naturally produce it to break down food and to break down anything that's in the actual bowels. Unfortunately, with a small bowel obstruction, it's too late. So the body will continuously produce more and more and more stomach content or juices or acids, trying to do it the best that it can to break that down. Unfortunately, it doesn't work, so it makes them nauseous and it makes them have vomiting and possibly diarrhea. The NG tube is meant to suck that out, so that way it gives them a rest and it at least makes the nausea and vomiting go away. You're definitely going to make them NPO. Obviously, if you put a tube down their throat into their stomach and they're eating and drinking, all it's going to do is suck it back out, so that makes no sense. But the NG tube is there to give bowels rest. NPO is also to give their bowels a rest, so that way, again, if whatever's going in is not coming out, there's no point in putting more back into it. They could do clear liquids if they are tolerating it. Obviously, you're going to turn the NG tube off. You can give them, some water, maybe some clear juices, just to see how well they tolerate it. This is being processed by the kidney, so you are still giving the bowels a rest. You're definitely going to do some pain management. Unfortunately, this is a catch-22. If they came in with a small bowel obstruction because they were taking pain medications that was causing the constipation in the first place, then you're just exacerbating that problem. But the NG tube is to help with it. Giving them fluids for hydration is to help with that. Giving them some, bowel rest is to help with that. So the idea is that you're giving pain meds because they are in pain, but then you're also doing other interventions to be able to help with that small bowel obstruction. So here's a picture of the NG tube. Again, it's going up their nose, down their throat, and into their stomach to be able to suck all that gastric content out. If that doesn't work and the small bowel obstruction does not resolve, then they will literally probably do surgery, go in, and either cut it out and so the intestine is back together, or possibly do some sort of colostomy or ileostomy based on where that small bowel obstruction is. And the last disease process is appendicitis. It's an inflammation of the appendix. It becomes infected, inflamed, or ruptured. So basically, we have what we call an appendix. It's a small little pouch that's connected to your large bowels that are. The appendix is useless. Unfortunately, sometimes it does get fecal matter in it, get stuck, and at that point, your body's trying to fix and try to figure out how to get rid of it. If it does get stuck and your body cannot get it moving, it will become infected, it will become inflamed. At that point, your patient will have, the pain is so intolerable that they will go to seek help before it ruptures. But I've had some patients that it either came on too fast or they really waited thinking that it would go away, and it didn't, and it did actually rupture. If it does rupture, then you're really kind of going back to the Crohn's and the colitis and all the lower GI problems that lead to the ulcers and the peritonitis. So again, if it ruptures, you now have fecal matter that's being expelled out of the intestinal tract and into the abdominal cavity, and this will lead to peritonitis and possibly sepsis, because now you've got intestinal content that is now in the peritoneal area, and that could lead to a blood infection. Assessment-wise, they're going to have pain in the periumbilical area that descends to the right lower quadrant. Abdominal pain at the McBurney's point. So I put a little link in here for a YouTube video. It's basically just showing you how to assess for it. You're going to have rebound tenderness and low-grade fever, an increased white blood cell count, anorexia based on nausea and vomiting, and then the patient is going to usually lay on their side, have abdominal guarding, and their legs flexing. So they found that that's what patients do to be more comfortable. Essentially, you're going to do surgical removal. Go back to your block 1 and block 2 as far as pre-op, OR, and PACU stuff. So, pre-op, making sure that the consent form is signed, making sure they understand the procedure, and, obviously the OR. And then PACU, basically, they'll come out, they'll be watched, they'll do vitals, so they'll make sure that the anesthetic start to wear off, and if they're stable, and then they'll move them to a med-surg floor. For you, getting them back, you'll find that they actually did the surgery laparoscopically. So basically, they're actually going to take 3 prongs that almost are kind of pencil size. They put those 3 in their abdominal cavity and basically cut the appendix into small little pieces and suck them through those 3 holes. So that's what laparoscopic means. Your patient definitely is going to be NPO prior to the procedure. You're definitely going to give them IV fluids for hydration because they are NPO. You're definitely going to pay pain management, whether it's pre-op and you do pain management because of the fact that they're having an appendicitis, or you're going to do pain management after surgery because now they've actually cut through skin, abdominal wall, muscle just to get to the appendix itself. So they're going to be pretty sore. Have them lay on their right side for comfort, monitor their bowel sounds, because again, if there's no bowel sounds, then they can't actually be on some sort of diet. But once the bowel sounds return, then you can actually put them on a clear liquid in advance their diet is tolerated. Don't do any heat, apply ice. They're definitely going to do an antibiotic. So they'll either do Zosyn prior to surgery or during surgery as prophylactically to make sure that nothing is brewing. Or if there was a rupture, they'll do Zosyn afterwards based on the idea that they want to make sure that they get all the infection. Don't do any laxatives or enemas because obviously you want things to move, but you don't want things to actually work quickly and move quickly because, again, you had a surgical incision and they've sewn all that stuff back together. So more GI meds. Again, you're going to have in Canvas a list of GI medications, and we will go over those in class and in lab. But here's kind of a quick breakdown. So we've got lactobacillus, which is good bacteria. We've got stool softeners such as dulcosate, stimulants. We'll cover mag citrate, and we'll cover Reglan, which will stimulate appetites. And again, I want you to know the med list in Canvas for the GI portion of it. Basically know what it is, how it works, and why you're giving it to your patient. So you're looking at symptoms, you're looking at adverse effects, just basic stuff. All right, so that is the end of this PowerPoint voiceover. If you have any questions, bring them to class. Definitely read your book. Definitely use the voiceover and the PowerPoint. We'll go into all this stuff in detail. This was really just to kind of give you an idea of what we're looking for, what we're assessing, and interventions we're going to do. So if you have any questions, bring them to class.